I'm Elena Marks, and I want to welcome all of you to our learning webinar today, where we're going to be building logic models. This is the first in our spring series of webinars from the Texas Consortium for the Non-Medical Drivers of Health. The consortium aims to improve health outcomes and reduce health disparities across Texas by helping health plans, health systems, providers of all kinds integrate non-medical services into their healthcare delivery. So a note on terminology. We're using the term non-medical drivers of health rather than the age-old term social determinants of health because we're aligning our language with the Texas Health and Human Services Commission. They have approached this by calling it non-medical drivers of health, and so we're going to do the same. HHSC has published an action plan on their goals to guide Medicaid and CHIP as it integrates NMDOH services as part of advancing quality. The state is investing in NMDOH programming, and last session, the legislature passed HB 1517, which provides Medicaid coverage for screening and navigation to address the NMDOH needs of pregnant women and their children. And Medicaid covers about half of all births in Texas, about 200,000 a year. So it's a lot of people who will have benefit from this program, especially now that we have 12 months postpartum. With all this exciting momentum, the consortium is both needed and timely. We're watching health plans, providers, health systems investing in these non-medical interventions on behalf of their patients and members. And in response, a growing number of community clinics and health professionals are implementing these programs to improve conditions that have a negative impact on their patients' health. The consortium is the only statewide dedicated space specifically for all stakeholders to come together to share, to learn, and to support and build a field of practice around non-medical drivers of health in Texas. We're really happy to have you with us today, learning alongside your colleagues and to teach you a really practical tool. I want to now introduce the newest member of our team and our new director, Dr. Charles Mathias. So Charles, take it on.
Thank you, Elena, and hello, everyone. I'm thrilled to be stepping into the role of director here at the consortium. Because the consortium has grown in its participation and offerings during the last year, it became clear we needed to deepen the bench. So I'm joining the team from my home base here in San Antonio, where I've spent 17 years as a researcher studying mental illness and substance use. And the influence of non-medical drivers has always been a key to my work. So I'm excited that the opportunity to address those drivers more directly through the work here at the consortium. We have an ambitious year planned ahead. We'll be rolling out a series of webinars like the one today. Plus, we're setting up an evaluation Genius Bar where NMDOH program administrators can receive free consultation with our expert evaluators. We have an upcoming listening session series to gather your insights, which will inform a report we're preparing on policy options for the state to consider in boosting health through NMDOH initiatives. Be on the lookout for information about our annual meeting in December. You won't want to miss it. And finally, we continue to collect information for our program index, which is the repository for programs underway in Texas. So if you have services going on in your organization, we'd love to talk to you. Thank you for joining us today for the webinar on logic models, which will be led by our presenter, Deborah Ganelin, and her colleague, Carol Perrette, will be joining to field questions. When it comes to building a new program, the first step is getting clear on your goals and how you will measure progress. That's where logic models come in. They're like a roadmap laying out exactly how your program will work and the results you're aiming for. In this session, Deborah will walk us through the nitty-gritty of mapping out your resources, activities, outputs, and outcomes, and to help you ensure you're staying on track in your desired outcome. Logic models are helpful for tracking your program progress and powerful tools for showing funders and stakeholders how you plan to make a real difference. Logic models can be used during planning, implementation, orientation, evaluation, and advocacy in your NMDOH programming. We've designed a session to be interactive so that you can build your own logic model. We've shared out a file, a fillable worksheet that you can jot down your thoughts along the way, and check the chat for a link to access that document. There'll be time after the presentation for Deborah and Carol to answer your questions. As questions rise, please post them in the chat, which we will be monitoring. This meeting is recorded and will be shared out on our YouTube channel after the event, and we'll also email you a copy of today's slides for your reference. Given the power of this tool, we're excited to have an expert to guide us through the design of a logic model. Here to introduce our speaker is her colleague, Carol Perrett. Carol's been with the consortium from the start and serves on our leadership council. Carol, over to you.
Good afternoon or good morning. Deborah Ganelin is a vice president at Memorial Hermann. She has been a key leader there in the community benefits space for over 30 years and has designed and led many of its efforts. She has always been committed to measuring an effort's effectiveness and often makes use of this tool. So you'll be learning from a true expert. Deborah, take it away.
All right, thank you. I'm gonna share my presentation. Okay, is it up correctly?
We can see it.
All right, well, thank you everyone for joining our webinar on the logic model, or as Carol and I always called it, did we actually make a difference? What we'll be doing today is we'll be talking about the purpose of the logic model. We'll talk about the components of the model, present an example, practice making one, and then end with some final thoughts. So what is a logic model? It is a visual expression of what you want to achieve, how you will achieve it, and what you need to achieve it. The model guides relationships between investments in a program and outcomes of a program. The logic model is a depiction of if-then relationships. If we invest these inputs, resources, then the activities can take place. If the activities take place, then the outputs will result. If the outputs result, then the outcomes will be achieved. Sometimes it is easier to say what something is not versus what it is. A logic model is not a strategic plan. The logic model and strategy are connected, but they are two different things. A strategic plan is a plan of action designed to achieve a specific goal. A logic model is a systematic way of thinking that follows set rules to arrive at valid conclusions. A logic model is not a research project. The research already exists. A logic model relies on existing evidence or the preponderance of the evidence, and then you apply your own principles of reasoning to achieve that evidence or end result. Logic models are essentially a chain of inputs, outputs, and outcomes. They come in different sizes and shapes and looks, and they vary in detail from very basic to very complex. There is one constant when creating a logic model, and that is that you always work backwards. So why is working backwards so important? It ensures that program activities will logically lead to the specific outcomes, and it guides you in the order of questions to ask. So on this slide, working backwards, we start with outcomes. And you ask yourself, what will be different and for whom? The question can be very simple, describing the ultimate result that you want to accomplish. Moving back to outputs, ask what conditions need to exist so that the outcomes can be achieved. Next, ask what activities, products, and events must occur so that your population will achieve the desired outputs, which will lead to the desired outcomes. And at the very beginning, from there, you determine what resources are needed to conduct these activities, reach these people, and make these outcomes happen. The process of asking and answering these questions drives the effectiveness of your logic chain or model. So when you start to do your work, you should always come back to these questions. I want to jump into a completed logic model, and then we'll start to break it all down. In this example, I want to improve health outcomes and quality of life and well-being by providing physical exercise activities within the green spaces of parks. My impact sentence is very simple. Parks and physical activity improve health outcomes and quality of life and well-being in my population. And someone might say, well, why parks? Why is this viable? There is plenty of research already out there supporting the power of parks and physical activity and their connection to improved health and wellness. So just a reminder, I am basing my work on research that is already out there. The challenge to me is how I go about implementing interventions and collecting data to show that I have achieved my impact statement. So for our program, what are the outcomes, both short-term and intermediate, that will indicate that we can reach this long-term goal of improved health and quality of life and well-being in our population? So moving to the right side of the page, a short-term outcome is a population's knowledge of the connection between physical activity and improvement in health, both physical and mental. A longer-term outcome is a population's changed behavior, given the knowledge they have embraced, connecting physical activity with health. To prove these outcomes, I will need to create a logical chain of data collection, interventions, activities, and resources that build up to these outcomes. Another short-term outcome is a population's motivation to monitor their health indicators. A longer-term outcome is the population's maintained improved health measures and their encouragement of others to follow the path that they have experienced to achieve health and wellness. Moving backwards to outputs, these are the conditions that need to exist and the data points that I need to be able to collect for me to be able to prove the reporting of the outcome data. So here, an output is not only the availability of park programs, but programs that are viable and have the correct synergy to engage. For example, if we are beginning with walking clubs, we need a membership that exceeds the American Hospital Association's guidance on healthy walking club membership so that attendees really feel a part of something and want to keep on coming. An output is not only the number of park attendees exercising, but that they are meeting or exceeding the CDC's recommendation for minutes of exercise each week. An output is not only the number of members participating in semi-annual screenings, but the number participating routinely, dedicated to learning their numbers and any other changes. Again, if these outputs, which are data points, are connected to the stated outcomes, then we have a good chance of achieving the outcomes that we want. Moving down to the yellow box of activities, we must identify activities that will support the outputs. An activity is access to programming that the population will respond to. Socially driven, engaging walking clubs, walk with the dog, dancing with the dog, Zumba and yoga, activities that will drive the outputs of park attendance and minutes of weekly physical exercise, which will then get us to the outcomes. An activity is creating an environment that responds to the population's social needs, keeping in contact with one another, having a voice as to what is done and not done, celebrating successes, again, driving the outputs of park attendance and engagement that will drive the outcomes. An activity is the provision of health screenings that can indicate to the population that personal change can occur. And then the resources we need to implement these activities are parks, fitness instructors, clinical staff, and celebrations. This logic chain communicates not only to others, but to ourselves and our team what success to our program looks like. It can be changed anytime to create additional successes, to change things that are not working. And in that way, it is a living document. I want to talk a little bit more about outcomes. At the beginning of the park example, I referenced short and intermediate outcomes. Short-term outcomes are typically fairly immediate. Change in awareness, knowledge, attitudes, skill, motivations. In the park example, the short-term outcomes are the park's population making the connection between physical exercise, sociability, green spaces with improved health and well-being. Intermediate outcomes can take months or even more years to emerge as they evolve changed behavior. The behavior is changes that are a result of the learning, the awareness that happened in the short term. In the park example, our longer term measure was populations maintaining their healthy behaviors as a way of life, and even then being able to show a decline in the incidence of chronic disease. If these outcomes are strong, we can deduce that our program is supporting the long-term goal of improved health and well-being. What leads us to do all of this? We have programmatic ideas. We need organizational support. We need to present the difference things will make, not just that we are doing them. So we can now practice building a logic model together, and you can use the worksheet Jackie provided. You can either make notes regarding your own program or make improvements on the one that we are doing together. So for the example, we have to identify a problem, and I've chosen to work on food insecurity. When identifying a problem, there are 4 questions you need to ask to make yourself clear that you're getting to the problem statement that you want to get to. Why is this a problem? For whom does this problem exist? Who has a stake in the problem? And what is known about the problem? So following those questions, I wrote the statement, 13.8% of Houston is food insecure. People experiencing food insecurity often consume a nutrient-poor diet, which may contribute to the development of obesity, heart disease, hypertension, and other chronic diseases. Moving down to the impact statement. I say, okay, what does success look like to me based on my problem statement? And it's access to food and promotion of education, reduces food insecurity, and improves overall health in our population. So based on that, my far-reaching goal I identify is reduce food insecurity and improved overall health of community members, my population. Going back down now to the short and intermediate term outcomes. What is the proof that we can show that we are making a difference? What is the proof that we can attain that kind of impact? So we start with those shorter term outcomes of changes in knowledge and attitudes. Can I create food programs or refer to existing food programs that will connect to the population's needs as they see their needs so that they will remain in the program for a meaningful period of time? Another short term can be, can I develop or refer to education programs that exist that resonate with the population's needs and are effective in helping them attain SNAP benefits, increasing their nutritional knowledge, helping them stretch their food dollar, and awareness of other food access opportunities. For longer term outcomes, I am taking the short term outcomes to the next level. I am focusing on behaviors and actions. Is there an increased percentage of community SNAP eligible members on SNAP? Are nutritional behaviors improved as a result of access and education? Are health measures improved as a result of changed behaviors and actions resulting from the access and education? Moving down to the outputs. How will we know that we are completing what we set out to do to achieve the outcomes? So the implementation of the outputs listed here should contribute to achievement of the outcomes. The number and type of food programs available, the number of approved SNAP applications, the number of community gardens that are available, pounds of food distributed, number of education sessions held, and the number of attendees. What's the coalition of partners working together to address food insecurity? I imagine there are many more outputs here that could be added. Just a reminder that these outputs are number oriented. They are the results of the activities that will lead to the outcomes. Outcomes should not be number oriented. They should be quantified as percentage change or presented as a rate compared to best practices. Both outputs and outcomes are tangible, but the outputs, the numbers, lead into the outcomes, which is the change in a population. Going down to strategies. So these are the activities that need to lead into the outputs. So I need access points for food programming. I need access points for people to be able to do SNAP applications. I need green space for community gardens and people who are interested in doing community gardens, opportunities to distribute nutritious food, the provision of education on nutrition and healthy eating and stretching your food dollar. I need to have a good group coalition of partners to work with who's each bringing their particular skills to the effort. And then going back to resources, and again, the funding, staffing, garden space, educational materials, sources, partners, all things that, you know, can actually be added to as you think through all the steps of your logic chain. It is the process of creating a logic model that is most valuable because it makes you think about what you are trying to accomplish and how you can do it. You need to ensure that your inputs, outputs, and outcomes link together in a sequence to achieve the desired result. Is the logic model truly logical? Ensure that your program as presented can be implemented with the available resources. If not, if you don't have all the resources that you need, what needs to change? What can you do? And you need to ensure that your one-page graphic communicates effectively. In summary, the logic model is a communication tool. It provides learning opportunities, documentation, and shared knowledge about what works and why. It is a tool to determine what contributes to a program and what does not, in fact, potentially detracts. People might have all kinds of ideas about your program and they might come to you and you can look at your logic model and decide, does that fit in or not? And the logic model is a living document to be used throughout a program's life. Final words on definitions. Don't mistake an activity for an output. Outputs are the accomplishments of the activity. Don't mistake an output for an outcome. Outcome is the change in the population served. And don't mistake an outcome for an impact. Impact is the long-term goal. Finally, the logic model can be created by anyone with knowledge of the program that is to be presented. There are no special skills required. It is the ability to make a difference. It is totally dependent on the process of repetitively asking the right questions. What is the real problem? What can we do that will make a difference? What evidence will show a difference? And then the overarching question at all times, are we doing the right thing right? Oh, thank you.
Thank you, Deborah. That was a great overview. Really helped illuminate the kind of concepts that drive this approach. We saw a couple questions come through, and please, if you have a question, please drop it in the chat. We'll monitor for those. One question that came up was, you know, we were able just in this exercise to kind of make our draft, at least, of our own logic model. And it seems so simple and easy as an individual process, but how do you find it helpful to engage other stakeholders to be involved in the development of it so they feel like they've got ownership and buy-in of a logic model?
Well, I think, you know, we did touch on the fact that usually you're working with a coalition of partners. And so you start at the beginning with them so that everybody can bring their expertise to the project. And it was actually a process that we learned from through a grant from Episcopal Health and the community, the Clinic Community Health Home Project, which just gave forms to engage with everyone so that people say, this is what is important to me. This is what I can already do for a project. This is what I want to do. This is how I can contribute.
I liked how you mentioned that this logic model is not like a rigid fixed thing that you do once and you're done. It's you call it a living document. Is there like a timeline that you should follow and checking back in or monitoring or about, you know, looking at it to see if changes need to be made or updates need to be made to it?
Well, a lot of that depends on if you're achieving your logic model, right? So if there's any point in that time frame where you don't see the connection, then you need to revisit it. And it's good just to revisit it if you have any change in partners, outputs, inputs, any of that, to make sure you're still on track. So it's one of those things that you should pick up routinely and just look at and check and make sure that you're still on track with what you thought before. And do not hesitate at all to make a change in it if you're not seeing what you thought you would see.
Thank you. Thank you, Carol. Elena, I see your hands up.
Yeah, I have a question, Deborah. So what you've just showcased for us and the examples that you used were things that y'all have done out in the community. A lot of our stakeholders are actually trying to develop programs for their own patients, so not community-based, but clinic or health system-based. Is a logic model appropriate for that as well? And are there any differences you would highlight in how you did your logic model for community-oriented work and how they would if they're doing it for patients or a health plan doing it for members?
Yes, we actually have done logic models for all of our programs, and some of our programs are hospital-based, inpatient navigation, ER navigation, and there is no difference in the process. You start with what you want to achieve and you work backwards.
So keep going on the work backwards, because someone put in the chat early on, so you do this backwards. Talk a little bit about that and how the logic model looks like it's all pointing in one direction, but you actually built it backwards, and why that is.
Right. Yeah, we did talk earlier about how the key is working backwards. The literature all says going backwards, but I know that the arrows are going the opposite way. But again, it's you know what you want to achieve. And so you have to start there. You have to start with what you want to achieve. And you have to identify that clearly so that you can then determine what will prove that you are achieving that. And so you can't start with resources. If you start with resources, then that will guide everything, versus what needs to guide everything is what you are trying to solve. You're trying to solve something. So what is that you're trying to solve? How will you prove that you will solve it? What do you need to prove it? And do you have the resources to do that? And it is the same exact process for hospital-based programs.
Yeah, and remember that for so long we've been kind of in a place where you measure activity, right? So you measure how many people, et cetera. And what this is really trying to do is pull you forward. And is all that activity making any difference? And what did you think you were going to achieve with that? And can you prove it? And go back to Deborah's comments about rates and percentage change versus numbers. And that will really tell you why you have to start there and move backwards.
And I think that point about rates and change bring up a question that's in the chat from Kantara John. She asked, can you explain more about the difference between outcomes and impact? Because you made a point to say how the data is different in those spaces. Can you expand on that?
So that's a good question, because I struggled a little bit with it in the presentation, is that there are 3 levels of outcomes. They're short-term, intermediate term, and long-term. And really your long-term is your impact statement. So it is that overarching goal that you have, is this is what I want to achieve. And so then your short-term and intermediate term outcomes feed into that. And there is that one slide, I can't remember what number it is, but it says, that the short-term outcomes, which are fairly immediate, you can easily say, prove through surveys or whatever, that oh, knowledge has been improved, awareness has been improved, motivation, opinions, it's all been improved. Then you go a little bit further to the intermediate where you can still prove things. You're taking everything to the next level. And based on your population that you're serving, it might be very controlled and you might be able to have some really good data coming out of that. Usually jumping to the long-term impact, the long-term goal, really that is where your research has come into play, because it's the evidence or the preponderance of the evidence that if I achieve this, then I'm assuming I will have achieved this longer term goal, which is more difficult to show, particularly if you're trying to show community level data. Does that help? I don't know.
Yes, thank you.
One of the things this brings to mind for me, Deborah and Carol, is I worked with somebody years ago who used to say, this is a solution looking for a problem. And a lot of times you find people looking at what the resources are and the activities they have, and then afterwards they're trying to figure out whether or not it's leading to anything. And to me, the way you framed out the logic model is a good reminder of start with the problem that needs solving, not with a solution.
Yeah, exactly. I think for too long we've gone the other way, right? And that's why we have things that, and we haven't changed many needles in Houston overall from a community perspective. And so if we get more disciplined and really connect those resources to what what those outputs are, we can get better and start moving those needles. I think the other point that Deborah made is partnerships. You know, we don't all have to do this alone. We can partner together and bring those resources together to really achieve those broader outcomes.
Another question we had is it relevant to build into the logic model some reference to your organization's goals so the leadership can follow like how this fits in? And if so, are there parts of the logic model that tend to be used to demonstrate that?
Ooh, that's a hard question. I think that's where I was sort of talking about the difference between strategy and logic model, is I think that our organizations are very comfortable with strategic plans, right? And so what helps us, especially in community benefits where we're doing different things, creation of the logic model can help support the ideas that we have for the strategic plan.
Thank you. That makes a lot of sense. I don't want to miss out on any burning questions folks have. Besides the chat, if you want to raise your hand, we can get you to unmute and post your questions out. Nancy Kwan asks, can you speak to how you navigate stakeholders who might have conflicting incentives but have or claim shared goals?
You know, that's a really good point. We are facing that a little bit in one of our parks, and that's really tough because we don't, as community people, we don't want to think that we want to always say we're collaborators, right? Not competitors or not having, and our style has been to, you know, everything is inclusive. We don't have to, we can work slowly. Lots of times our work in the end survives the conflict. So I would just say that those kind of things just take a little bit of time.
And continuing conversation, right? So don't leave it there. Continue to talk and continue to work through that with an organization over time.
Does the competing incentives tend to play out in the logic model kind of at the resources and activities stage where you're defining what you have to work with and what you're really allowed to spend time on?
I'm sorry, can you ask that question one more time?
For the differences in incentives, does that kind of play into the logic model at the resources and activities phase of?
Well, I guess that's the whole point of having a coalition and laying everything out. And as Carol said, just continuing to talk, and lots of times, you know, you contribute and others want to contribute equally, right? It does seem to work out with time.
Well, and the kind of conflicts you were talking about, like with external stakeholders, you can have that with internal stakeholders, right? Because within your own organization, there are people in different departments or levels or whatever who have their own goals and objectives that may or may not align with yours. Can either of you talk about how you navigate within your organization if there's not total buy-in, or how the logic model is helpful? You mentioned it as a communication tool. How does it work that way?
I think one of the keys about using the logic model is people can see the pathway and they can see ultimately what you're trying to achieve. And if you're not in this space, if you're just, you know, you're talking about a food security problem, or you're talking about work in the parks, people are asking, well, how does that affect us? What does that bring to us? And so you have to paint that picture of why it's important to the organization as a whole if they're going to put their resources in it. And this tool allows you to do that in a framework that people can see the connections. So if I have a quality issue with patients that I'm working on, maybe it's related to their food insecurity because they're coming in, you know, debilitated when they come into the hospital. So if I want to achieve my quality goal, maybe this can help me. And it's drawing those parallels and those connections for people that can really cement the change and cement people really getting on board with what you're doing.
I see another question from Carla Granado. She says, I'm curious how other healthcare providers think about outcome indicators, since NMDOH is so hard to directly correlate with change in clinical outcomes. For now, we plan to track metrics like SNAP enrollment, transportation, and missed appointments. And so how do you think about outcomes being longer term or further out? How to track that and link it with your activities?
Well, we've had partners, healthcare partners with us. We collaborate quite a bit with MD Anderson and their Be Well communities, where all of their work is around non-medical drivers of health. So we try to collaborate in shared communities. Texas Children's was supportive of us in a park effort. Harris Health, we work with them often. We have shared projects. Some of them are hospital-based, like ER navigation. We learn a lot from them and their food programming. So there's actually much more collaboration amongst healthcare systems than it might appear.
So Charles, think of it, if you're doing a food pharmacy and you're doing it for diabetics, you can actually measure clinical indicators. Did their hemoglobin A1C drop? You know, is their glucose in control over a longer span of time? So you can make those correlations if you do this work correctly. It just takes longer time maybe to to get there. But ultimately, in that, those are those outcomes we're trying to achieve, right? That percentage change.
Yeah, like Deborah was mentioning, I think the time scale on this is the impact really is those longer term things, and it just takes time to see those.
But it's really important that you are clear about what you're trying to achieve at the beginning if you ever want to see those.
Right. These programs lots of times will involve partnerships between health systems or providers and community groups. And as a result, some of those partners might not have access to the data point that they need to kind of close the loop and know what happened. Like, how do you navigate that or deal with that? Like, that seems like a reality of working in this space. How do you deal with that?
Mm-hmm. Well, that is a part of the beginning of working together and creating your chain, because you are identifying what you're going to be able to collect and what you're not. And sometimes if you don't have fully robust data, you collect sample data. But, you know, you're clear mostly on what do I need to collect for me to prove, you know, my efforts.
So don't let access to the full data be a barrier to taking action. There's other more
Absolutely.
limited.
Absolutely. We can use sample data.
Just polling the audience for any other pressing questions or ideas or comments even that you have from today's presentation.
There's a question in the chat about whether any CHW organizations are using logic models. I don't know the answer to that. Does anybody, either among our speakers or anybody in the audience, know about the use of logic models by CHW organizations or organizations deploying CHWs?
Oh, sorry, go ahead.
Oh, hi, this is Vanessa Saria from Cardia. How are you? We're a certified training provider for community health workers. And in the various projects, I know that Dr. Rosenfeld out of San Antonio, there's a big project there that we're using logic models. He's been doing presentations on Data 101 and logic models to community health workers. I don't know if that helps. There's a series of trainings that are going on for community health workers to help them with data management and qualitative and quantitative analysis of public health data. And so anyway, Charles, you know Dr. Rosenfeld well, and I'm sure many of you do too.
Thanks,
Vanessa, can you drop it in the chat, please, so that Roger, who asked the question, can get it? Thank you.
I'm Lori Long with Texas Health Resources, and our Community Health Improvement Department has a program for continuum of care, which utilizes community health workers and very much so uses a logic model. Like you said, logic models are a great platform to kind of provide that plan of action so you get those final outcomes and deliverables for your goals. And so we have basically identified that there are a lot of patients that come in that have non-medical drivers of health that are causing them to re-enter into the ED. They can't get the pharmacy drugs because they can't afford it, or they have transportation needs. There's several different non-medical drivers of health barriers. And so we've implemented the use of CHWs within the system. So before they're discharged from an inpatient stay, they really are assigned a CHW so we can follow them after discharge, because normally hospital systems, your continuum, your care transition manager usually is with them, helping them understand their regimen, their goals. But once they're discharged, then you don't know, right? Are they following up with appointments? Are they having challenges? So we basically added that to the system and helped the patients get connected to the resources that they need in the community, help with their awareness and ability to understand how to access those resources and utilize those resources. So the outcomes are reduced emergency visits, increased use of primary care providers to be preventative and maintain your well-being goals. And so there's a lot of different indicators that we have that improve health and well-being. And we can capture some of those clinicals, right, as well to show health and wellness outcomes. So we definitely use that as one example of some of the programs that we have.
Good afternoon. My name is Mordia Gentry. I train community health workers for the DFW area, but I also work with a company out of Chicago, an MCO, and we just started using the logic model with CHWs for CHW embedment, where we're embedding the CHWs in the DFW area with the 61 pediatricians that we work with. And we're also working with the ER interventions, and we're going to be using the logic model for that with CHWs calling and reaching out to patients that are overusing the ER in the DFW hospitals.
Hi, I'm Monique Johnson. I'm a supervisor for the CHWs at UT Health, Healthcare Transformation Initiatives. We are not using the logic model. We are using a tool in Epic where we assess patients for non-drivers of medical health.
Thank you for the discussion on CHWs and training. It sounds like there's a lot going on in that space. Any other thoughts people want to elevate before we get to the end of our time? Well, seeing no other questions, I'm going to close us out with a couple comments just about the consortium and what to expect next. First off, thank you, Deborah, for your presentation and enlightening us on how to approach logic models. I feel like you just demystified it and made it a much more accessible tool for our audience. And Carol, thanks for joining in the Q&A. Before we sign off, I wanted to alert you to the consortium's program index. This is a catalog of NMDOH programs across the state that are sponsored by health system organizations like plans, providers, and hospital systems. This index is a single repository for NMDOH programs that feature abstracts with searchable fields about the program sponsor, the drivers of health that they address, target populations, health conditions, locations, and evaluation status. So our goal with the index is to serve as a resource for anyone working in this space to know what's happening, what's going on, at what cost, and for what benefits. But the program index will only be as robust as you make it. So we'd like to invite you to contribute to this effort by connecting with Jackie to add an abstract about the NMDOH program you are implementing. The link to the program is in the chat. Please check on this link and bookmark it for when you can add your information. Please join us next week, May 28th, for our next webinar on Introduction to the Social Interventions Research and Evaluation Network, or SIREN, which is a key national resource on NMDOH programs and data. Thank you all for the robust conversation today. We're grateful for your input. We really want you to feedback from you about this webinar. You'll receive a short survey from us in the next several days. This consortium is going to be what we make of it, so we need to know what you want so we can deliver that. Please stay in touch with us. You can always check our updates on our website, driversofhealthtx.org, and our consortium manager, Jackie, is reachable at jk90@rice.edu. Thank you all for your attendance and have a great day.